Okay, so this section is going to look at considerations for individuals with neuromuscular conditions and disorders. So just a little review of the nervous system and looking at the different parts. So the nervous system consists of two different sections. You have the central nervous system, which is essentially the brain and the spinal cord. And then you have the peripheral nervous system, which is basically the connection from the brain to the rest of the body. So when you're kind of looking at the anatomy of the nervous system, again, central nervous system, you have the brain and the spinal cord, and then from the spinal cord kind of coming out, you have your nerve roots, and then that's where all the nerves kind of branch out and control the rest of the body. When you're looking at the peripheral nervous system, you also have a further division. So the PNS is divided into the somatic nervous system, which mediates the volitional movement. So if you just think of, for instance, just your muscles contracting, your volitional movement, that's controlled by the somatic system. The autonomic system, which is responsible for control of the internal organs, and then you have the enteric system, which regulates the gastrointestinal system. Obviously, that's another involuntary system. And then within the PNS, you also have your sensory nerves, which are your ascending nerves, or you're also known as your afferent nerves. And then you have your motor nerves, which are your descending or your efferent nerves. So looking at the neuromuscular disorders, we're going to be looking at obviously disorders that result in a decline in function of the body's nervous system or the muscular system. So we're kind of seeing, systems being involved here and related. Obviously, when we look at the neuromuscular system, we're looking at the nerves, their abilities to control the muscles of the body. And these disorders that we're going to look at are going to be classified as either progressive or non-progressive in nature. So the progressive disorders basically involve a continuing and progressive deterioration or functioning of the nervous system. So that's going to be like when we talk about multiple sclerosis, Parkinson's disease, and muscular dystrophy. Those would be your progressive disorders. Your non-progressive disorders do not get worse following the initial episode. So, the start of it doesn't tend to get worse after that. Whatever the episode is that causes the disorder, that's kind of the functional loss that you get stays the same. Those would be the disorders like cerebral palsy, stroke, head injury, and spinal cord injuries. So multiple sclerosis is a neurodegenerative autoimmune disease where the myelin layer, which myelin's basically like an insulating layer on some of your nerves. And what that does is this disorder deteriorates that myelin layer and it weakens the electrical signals. So on the nerves, the myelin's a fatty substance that covers it and kind of insulates it and allows the electrical signals to travel a little bit faster. The demyelination ends up causing that electrical signal to not travel quite as efficiently. There's some other examples of neurodegenerative autoimmune diseases that are present. Guillain-Barré syndrome, leukodystrophy, and Charcot-Marie tooth disease are other examples of neurodegenerative autoimmune diseases. Multiple sclerosis could affect both the central nervous system and the peripheral nervous system. Some of the symptoms that you get from MS are basically going to be due to the inconsistent or weak nerve transmission that occurs. So, and again, it's kind of a variety of symptoms. Fatigue, obviously numbness, tingling, which is something you experience with a lot of neurological issues, bladder dysfunction, bowel dysfunction, vision problems, vertigo, cognitive dysfunction, pain, spasticity, depression are all different things that individuals with multiple sclerosis, again, depending upon what nerves get affected, could cause various symptoms with individuals. An interesting point is that the lifespan with multiple sclerosis is similar to that of healthy individuals, with obviously as time goes on, further and further neurological decline occurring in the individual as they get older. Again, as we're looking at multiple sclerosis, again, these individuals are going to typically have a normal lifespan, but just with the further decline in neurologic functioning. There's two types of MS. You have the relapsing remitting MS, which is about 85% of the cases. That's where individuals will experience a clearly defined exacerbation or flare-up followed by remission where the symptoms stabilize. And then half of those individuals will be considered secondary progressive after about 10 years. So with secondary, what it means is when they become secondary progressive, that basically means they're going to have less recovery following their attack. So in other words, initially if they're relapsing remitting, they have, they can have a pretty long period of time in between, symptom flare-ups, if you will. Over time, though, they could become what we would call secondary progressive, and that's when they get less recovery following the attacks, and their condition continues to deteriorate. Primary progressive, this is about 15% of cases, and this is just continual progression with no relapses. So basically, the disorder, continues to progress over time. They don't go into, they don't necessarily have the relapses. Now, again, knowing a little bit about the pathology is important. Now, the causes of multiple sclerosis are unknown, but there are several possibilities. Again, we talked about the autoimmune influence possibly. So they do believe there's immunological influences. So basically, your T cells, which are part of your immune system, attack the myelin sheath. So again, an autoimmune disease is any disease where the body's immune system attacks itself. Okay, and there's various autoimmune diseases. So in this case, you look at the T cells basically attacking the myelin sheath as if it were, a virus or something like that the immune system would attack. There's environmental causes, and the reason why this comes up, your textbook talks about this, is that there does seem to be a higher incidence the further you live from the equator. So, for instance, less sunlight and possible lack of vitamin D from the natural sunlight possibly being a cause. There's possible infectious mechanisms to this. So they believe that individuals maybe were infected with a virus that can possibly cause the demyelination. And again, we look at genetics. So again, having relatives with multiple sclerosis increases one's chances of developing it as well. As far as medications are concerned, and again, make sure you review your medication tables. So again, disease-modifying interferons are basically going to be medications that reduce the frequency and severity of attacks, but have the potential for reducing the capacity to exercise. So if they're on an interferon therapy, that's going to be something you're going to want to consider with an individual's exercise. Corticosteroids get used to help reduce the inflammation. It should be noted that, again, you could also have some reduced exercise capacity with them as well. Other medications are prescribed as well. So like I said, take a look at your medication table when you're looking at that, and that, just to kind of go through some of the possible side effects that would occur with the medications used to treat this. So looking at multiple sclerosis with exercise. So again, participating in exercise will result in a higher quality of life, but it won't slow the progression of the disease. So in other words, the disease will continue to progress in nature. However, again, by increasing, a person's just physical capacity through strength and aerobic training will certainly do that. Resistance training has been shown to be effective at improving, strength, muscular endurance, fatigue threshold, power, walking speed, balance, quality of life in individuals with multiple sclerosis. So, and again, obviously, just the work capacity with the aerobic work can assist as well. So again, review your exercise recommendations. Persons with MS may benefit from using a seated resistance machine as opposed to an upright free weight activities if their balance is compromised. So if their balance is really compromised to start, you may not be using a lot of, standing upright free weight activities. Start with the seated resistance, build some of their strength, And maybe work in some light balance training as well could certainly benefit. Non-weight bearing aerobic exercises are suggested. Recumbent cycling, aquatic exercise, light to moderate intensity can be a benefit. They recommend static stretching as opposed to dynamic stretching for these individuals. And the reason basically for that is just because of the balance limitations that they have. Plus, they may have some spasticity in their muscles, so that can make it a little harder for them to go through like a fluid motion to do a dynamic stretch. So, for some of the just mobility purposes, you may want to start with, and again, it just kind of depends on their presentation, but typically static stretching will be preferred from them. And again, here's some of the suggestions for the resistance training. Here we're going a little bit lighter intensity wise as far as the weight's concerned than we've seen in the past. So they recommend a 15 repetition max and 1 to 3 sets each, about 4 to 8 exercises. So some precautions. So some of these things are pretty important. So particularly try to keep exercise in cool temperatures. Warmer temperatures, warmer environments tend to exacerbate symptoms in individuals with multiple sclerosis. So that's a really important point to remember. If they do have a flare-up, restart only when it's fully subsided. So discontinue that. And again, be prepared to properly incorporate, wheelchairs, canes, walkers, be thinking about those Americans with Disabilities Act recommendations and some of the things that, if you're in a facility, make sure to kind of mind that as well. But you may have to be prepared to utilize some of their equipment, maybe even as a part of exercise, maybe using the walker and doing some, balancing and things like that may become a necessary thing. So moving on to Parkinson's disease, the second most common neurodegenerative disease, progressive brain disorder. It's caused by the death of neurons in the substantia nigra region of the brain. The significance there is the neurons in the substantia nigra produce a neurotransmitter called dopamine. So dopamine does a couple different things in the body, but the thing most impacted here is dopamine regulates smooth, coordinated, voluntary movement. So Parkinson's disease, one of the major impacts it has on a person is their volitional movement. So that lack of dopamine produces your hallmark signs, and that includes, tremor in the limb, bradykinesia, rigidity, and poor balance. This is a very difficult disorder to diagnose, so no one test could necessarily diagnose the disorder, and each case is very unique. And the progression of it varies very much per individual. So many times, again, this obviously requires a neurologist to diagnose, but additional blood work and different types of tests may be necessary just to rule out other disorders. So they'll do blood work and they'll do MRIs to rule out some other things. And then, if the symptoms are still there, that's pretty much where your diagnosis will come from many times. So looking at the medications, again, there's no medications that slow or stop the progression of it. And again, the most prominent symptoms are going to be due to the lack of dopamine in the body. So the most commonly prescribed medication many times is going to be levodopa. So how the body kind of uses the levodopa is that basically the brain uses it to help produce dopamine. So levodopa and other dopamine agonists are some of your more common medications utilized to treat Parkinson's disease. Again, so common side effects of that are nausea, loss of appetite, lightheadedness, confusion, hallucinations, reduced blood pressure. And again, exercise capacity may be limited or the risk of injury may be greater. So again, having an awareness of this is important if you have a client that is taking that medication. Some other things that can be utilized, anticholinergic medications can be used to reduce spasm. They also, though, with them carry, again, side effects. Here you see some of them: blurred vision, drowsiness, and confusion. Catechol O-methyltransferase inhibitors are basically used to prolong the duration of levodopa. So this is a medication that would help to increase the effects of the levodopa to kind of act as an agonist with it. And the side effects for that include drowsiness and dyskinesia. So dyskinesia is the impairment in voluntary movement. So basically it involves a lot of uncontrolled involuntary movement that a person would be doing. And just to go along with that, so I obviously gave you the definition of that. Again, as we're going through some things, there may be times where like I use a medical term and I don't describe it. Make sure that you know, if it's a medical term that you don't know, that you make sure that you look it up. Because in the course of the conversation, I may use one that maybe you haven't heard before, and just make sure that you review that. So the effects of exercise, so particularly for Parkinson's disease, resistance training, again, we talked about, you know, some of the benefits of resistance training with multiple sclerosis. With Parkinson's, again, very similar positive effects: increased muscle strength, mobility, walking capacity, endurance, balance, increased fat-free mass, which again has other obvious health benefits. Some of your other successful protocols with, you know, creating programs also involves including balance training. So like with a lot of neuromuscular disorders or disorders affecting the nervous system, balance training is going to be very important. High intensity training can be utilized as well, and a lot of high force eccentric training can be beneficial with Parkinson's disease. So again, review your exercise recommendations. Recommendations, follow those many times just for older adults. Just because not a lot of research has been done to establish specific recommendations. And again, just like anything else, if it's a beginner, begin with your light to moderate resistance, multi-joint exercises. Again, we've talked about the importance of that repeatedly. And again, balance training can be included to help reduce the risk of falls in individuals with this. Aerobic training, again, start light to moderate, about 30 to a little less than 60% of VO2 max or heart rate reserve, 55% to a little less than 75% of max heart rate, again, or you can use rating of perceived exertion. Again, you can progress and gradually increase the number of sessions. Again, emphasize safety. Again, slower walking, you know, again, they may have less coordination or they may have poor balance, can increase their risk of injuries. So make sure that you're doing that. Treadmill walking a lot of times is contraindicated just because it could be a little, if they have balance issues, many times the treadmill can become a problem. Overground walking or biking is typically preferred for these individuals. So particularly if they do have tremors, they do have a lot of loss of balance, some upright exercises might not be safe. And that the same would even go, like, again, if you look at like your free weight exercises, if there's a significant balance problem, you'd want to consider that. Again, just some other recommendations for these individuals. Again, training at less busy times for them or in less crowded environments can help with some adaptation issues that they may have with the environment. Consult with the physician concerning the timing of a lot of the medications. Symptoms are usually controlled just after medications have been taken. And obviously you have to be concerned about, you know, possible negative side effects. And then just monitor blood pressure to avoid orthostatic hypotension is important for these individuals. So muscular dystrophy is a group of progressive muscular disorders characterized by damage to the muscle structure and then the progressive weakness that accompanies that. And muscular dystrophy, again, there's various types. We're going to talk about two in particular, but basically in the case of many of them, there's basically dysfunction with a muscle protein that's responsible for keeping the muscle cells intact. And that's what causes that damage to the structure and then the progressive weakness. The two most common that you're going to be looking at are Duchenne muscular dystrophy and Becker. Both are caused by the dysfunctional muscle protein, and that's going to be dysfunctional, what we call dystrophin. And again, what dystrophin is basically responsible for is keeping the muscle cells intact. Individuals with Duchenne's muscular dystrophy completely lack dystrophin, while those with Becker's have it, but it only partially functions. Both of those are inherited from the mother, and here we're just showing you the chance of inheritance as this is a genetic disorder. So early signs of the Duchenne muscular dystrophy is failure, you'll see this in young kids, their failure to keep up with peers in like physical activities. They talk about what's called Gower sign, which is using the arms to come up from the floor, and also pseudo hypertrophy of the calf muscles. So, they'll have these calf muscles that look like they are hypertrophy, but it's actually not muscle tissue, it's scar tissue. And many times that those same symptoms will develop for Becker muscular dystrophy, but usually they occur a lot later in life. Lifespan does get affected with this. Duchenne muscular dystrophy, the current lifespan is in the 30s. Boys with Becker muscular dystrophy tend to survive into mid or late adulthood. With Becker muscular dystrophy, locomotion becomes difficult. Eventually, a wheelchair becomes necessary with the disease progression. And many times cognitive impairments do accompany it as well. Another type of muscular dystrophy is what's called myotonic muscular dystrophy. This is the most common adult form of muscular dystrophy. Again, here it's just showing you who it primarily affects. It actually affects women and men equally. It is inherited. And you see here the chances of individuals getting it. It's usually seen in people 20 to 30 years of age. People with myotonic muscular dystrophy are unable to relax their muscles. So again, these individuals have a higher rate of cognitive impairment. The disease progression is slower. Again, this disease causes contractures in the muscles. So whereas with the other two, you had an issue with the actual muscle structure, here you get contracture problems. Other things that develop are breathing and swallowing problems, cataracts, heart problems, and insulin resistance. 6 other types of muscular dystrophy are congenital, Emery-Dreifuss, fascioscapulohumeral, limb girdle, distal, and oculopharyngeal. So these are all other different types of forms of muscular dystrophy. So medications involved with muscular dystrophy, corticosteroids are administered to help treat some of the symptoms. It could help slow the progression of the disease. Obviously, there's the side effects, which we've seen before because we've talked about corticosteroids, depression, anxiety, high blood glucose levels. Many times, heart medications like ACE inhibitors and beta blockers are commonly used to treat heart conditions that are many times associated with the muscular dystrophy. And again, your side effects that can occur from those medications, many of which we've talked about before in the cardiovascular systems chapter. So the effects of exercise, and we'll talk about this more, we'll expand on it a bit, but traditional resistance training is generally not recommended for individuals with Duchenne's muscular dystrophy and Becker's muscular dystrophy. If you have the ability, though, to do submaximal isokinetic training, that could actually increase strength. Aerobic exercise causes fatigue, but does not appear to impact the normal activity the following day. So we'll kind of talk about how we can kind of coordinate the aerobic exercise. But traditional resistance training many times cannot be performed with individuals. Usually you're looking at either utilizing a machine or like elastic tubing or something like that. You're not usually doing traditional resistance training exercises. So look at your guidelines in Table 8.3. Aerobic exercise should be low impact. Perform 1 day per week, and you could gradually progress that, light to moderate intensity. Resistance training should be isokinetic with concentric movements only. So you actually want to avoid eccentric movements. Again, begin 1 day per week at a very low intensity, and you could slowly increase your volume over time. Usually you're looking at a lower percentage of a 1 rep max, about 40 to 60%. Prevent maximal exertion. So, I've kind of talked about with conditions where like some higher intensity training, because obviously going high, there's a lot of physical benefits to doing higher intensity training, whether that's higher intensity conditioning or resistance training. This is a condition where that would not be the case. So prevent maximal exertions. Stretching should be performed very slowly. Again, if you think about it, particularly with like Duchenne's and Becker's, it's a condition where the muscles degenerate. So, doing exercise that's going to cause further damage to the muscles, they're not going to be able to repair and recover like a healthy person would. And in particular, eccentric activity should be avoided. And again, that's because if you remember from a lot of your previous classes, the eccentric contraction is what produces the most structural stress and damage to the tissue when you're doing your resistance training. So you would want to avoid that when as they're actually doing that. It should be noted that, again, some of it may depend upon the type of muscular dystrophy. And the reason why I'm saying that is because one study did actually show that high intensity resistance training in those with myotonic muscular dystrophy actually showed improvements in 1 repetition strength. But remember, in myotonic muscular dystrophy, that's a type of muscular dystrophy that has a different pathology and pathophysiology associated with it. It's not a muscular dystrophy where there's an actual issue with the muscle protein dysfunction. So again, it could depend upon the type, but typically many times with muscular dystrophy, traditional resistance training won't be taking place. All right, cerebral palsy is a group of non-progressive permanent neurological disorders that are caused by a variety of birth injuries. So cerebral palsy is something that would start by some type of issue that occurs at birth, and then depending upon what gets affected, there's various types of functional issues. So again, it affects the central nervous system and is characterized by limitations in motor control that affects body movement and posture. So the most common symptoms are spasticity and hypertonia, and that results many times as far as the carryover into functional day-to-day activities, particular to a lot of different types of gait abnormalities that you see listed here. So a crouched gait, a scissoring gait, toe walking, those are some of the gait abnormalities that you have. Many times motor deficits that get displayed include lack of motor coordination with volitional movements, also known as ataxia. Again, tight muscles, exaggerated reflexes, which is basically your spasticity, are other things that these individuals will typically experience, again, depending upon the severity of the cerebral palsy. So your three main forms are spastic, ataxic, and athetoid dyskinetic. Your spastic cerebral palsy makes up about 75% of the cases, and that's a result of damage that interferes with the uptake of gamma aminobutyric acid, which is a neurotransmitter that's actually an inhibitor in the body. So what basically the limitations in the GABA uptake interferes with normal control of neural excitability and muscle tone. So that substance helps you to control how much muscle tone that you have in your muscles. So that the lack of it basically creates that spastic form of cerebral palsy. Ataxic cerebral palsy affects the cerebellum, makes up fewer cases, and usually this creates a lot of limitations in coordination. Usually makes tasks like writing and upright balance very difficult. The cerebellum is kind of a coordinator again of movement, so damage there would create that. Athetoid dyskinetic cerebral palsy is characterized by mixed muscle tone that kind of limits the ability to hold upright and walking postures. This particular form also limits the ability to kind of hold and control, small items and manipulate small items because, again, they kind of lack the ability to kind of control their motions well. So cerebral palsy, as I talked about, it's going to be caused by a complication that affects brain development that's usually going to arise sometime early in a child's development, whether that's during the pregnancy, during childbirth, or even up to 3 years old. It could also be caused by an infection from rubella or toxoplasmosis. Rh factor incompatibility with the mother or some other unknown cause can also do it. Also, oxygen deprivation or head trauma can cause the cerebral palsy as well. I mean, the bottom line is again, it's something that it occurs early on in life, and then it's depending upon the area of the brain that gets affected or what gets impacted is going to be based upon the symptoms and the type of cerebral palsy that the individual is going to present with. Regarding medications, the seizures are likely a secondary symptom of cerebral palsy, so many times anti-seizure medications are given. Again, these can limit exercise, even individuals, for instance, that have epilepsy. Sometimes the hardest thing for them is making sure to take their anti-seizure medication because many times they don't want to take it because it negatively affects their exercise. However, if they don't take it, they run the risk of having more seizures. So that's something that you want to make sure that the individual is educated on. Antispasmodics are probably some of the more common things. Again, here they could also induce lethargy and drowsiness as a side effect. So looking at the effects of exercise, so it should be noted that in looking at cerebral palsy, physical work capacity for individuals with cerebral palsy is less than half of that of their age-matched peers. So exercise is going to be really important. So again, you're going to want to help improve their capacity. And both aerobic training and resistance training has been shown to have positive effects on both their VO2 and muscle strength. And it also helps in improving their gait capabilities. So certainly a lot of benefits there, all the more important for individuals because of just their lack of physical work capacity from this to help improve that. Again, review your tables. Again, with variations in functionality, it's hard. We just talked about, many the different types of cerebral palsy and how it impacts individuals in different ways. So specific recommendations aren't well established. Here's just what you could look at as far as aerobic training is concerned. Again, a slightly lower intensity you're looking at here, and again, you could also divide into multiple shorter bouts, which may be better for somebody, particularly for somebody who is really deconditioned. The resistance training recommendations have two exceptions. Free weights might not be appropriate if somebody has balance issues. So if someone has a lot of limitations in balance, and we've talked about this with some other disorders, they may not be able to use free weights. And again, intensity just has to be calibrated based on the individual's capabilities. So again, it's just like everything else. Again, these individuals will probably have discussed with their with their physician, that they're interested in doing this, or maybe recommended to them, and then you could kind of, based upon the type of cerebral palsy they have and some of their limitations, you could kind of modify the resistance training as you need to. So again, just some other things to look at. Again, arm exercises could be appropriate for some individuals. Again, you may have to make modifications to equipment. Again, make sure you're using, like, for instance, straps for bike pedals may be necessary. Muscles under spasm should never be forced against the spasm. Okay, so if they have spasm in a muscle, you certainly don't want to force any muscle activity, particularly on the opposite side, because if that that muscle in spasm, if it's forced and they're forced to go against it, they could end up possibly tearing or injuring the muscle. So, whatever muscle's in spasm, that's something that you're likely going to have to work around with the individual. Again, as far as the resistance training, the recommendations are very similar to a lot of the other conditions. They recommend that 60 to 80% range in the 8 to 12 repetition. You may have to lower it slightly, and again, just be aware anatomically of some of the things regarding spasm and things like that, or the spasticity that might be there. So never force range of motion on somebody if they have that spasticity.